those of you who weren't aware, if there had been a Nobel Prize awarded during the late 19th century, it is virtually certain that Sir Patrick Manson would have been one of the first recipients, because it was in 1879 that Manson, working in Amoy in Taiwan, was the first person to demonstrate that an insect transmitted an infectious agent. And that happens to be filariasis, which I've been privileged to work on over the last few years. And this society celebrated the centenary of the foundation of medical entomology in 1979 at a meeting in the old Manson house. And to receive the Manson Medal from this society is indeed a great honour, and I hope this lecture reflects the historic traditions of the Manson oration, many of which I've had the privilege of attending. Now, when I was president of the society in 2007, I gave a lecture on the topic of neglected tropical diseases, which were beginning to become a brand in response to various publications with which I and other colleagues, including Alan Fenwick, who's here, have been associated with. But now, nearly 10 years on, we are at a different stage and moving into the post-2015 agenda in the context of the Millennium Development Goals. And it's this issue that I want to try and address whilst reflecting on where we've come from since I gave the presidential address in 2007. And it all stems from some publications that were published in 2004, 2005, and then the advocacy in which Alan Fenwick was certainly involved to get these statements in Tony Blair's Commission for Africa report, which was endorsed at the Gleneagles Summit in 2005. And that was a starting point and a platform for WHO to start to become involved in making NTDs a higher priority. Now, there are 17 NTDs, which are the core NTDs, and I apologize to members of the audience who have a particular focus on other of the NTDs, which I'm not going to discuss in any detail or necessarily allude to. But since 2005, 2006, when the WHO Neglected Tropical Disease Department was established, WHO has been in the lead in formulating policy, and for the Director General herself to take a particular interest in these diseases. Now, you'll see these reports which are reflected in the publications of WHO, including the one on the top left, which is the global report from TDR on infectious diseases of poverty. But there are other diseases which are important, but which are not in the core. And while snakebite is not an infectious disease, it has a huge global mortality. It is probably causing 200,000 to 300,000 deaths per year, nearly as many as maternal mortality. And other diseases like podoconiosis, which Gail Davey has highlighted as being really important in specific locations in the world. Now, in 2012, the London Declaration, I published at the request of the Gates Foundation an editorial, and I wanted to highlight in that editorial the concept of neglected tropical diseases, NTDs, becoming a brand, but also in that to reflect on what responsibilities of that were in relation to the people who give us the drugs, the responsibility of the donors, and also the countries themselves. But in that context, perhaps the most telling figure which has emerged over the recent years is one that comes from a friend and colleague, Bernard Lisa, who works now at Georgetown University, who, in analysing the amount of official development assistance for health that was allocated to these diseases, despite the fact they infect over 1 billion people, the figure was less than 1%, 0.06%. Now that figure is really important because Bernard's subsequent analysis has shown that that figure's not changed despite the advocacy for NTDs. Now, I showed this slide, or an earlier version of it, in my presidential address, that if you were an alien approaching the planet in 2007, you would only appreciate that there'd be about 3 diseases on the planet: HIV, TB, and malaria. That situation, I think, has changed a little. Certainly the NTDs are on the agenda, as reflected not only by the London Declaration and the commitments made by the partners at that declaration, but also more recently by David Cameron in his report with the presidents of Indonesia and Liberia, where NTDs, as I'll show you in a minute, are included amongst the health targets post-2015. Now, at the meeting in London held at the Royal College of Physicians, the great and the good, including Margaret Chan, Bill Gates, Andrew Whitty, and Stephen O'Brien, who's been such an ardent supporter of this cause, endorsed the WHO roadmap for the control, elimination, or indeed eradication of these diseases, and committed themselves to expand programs and drug access, advance research and development for the next generation of products, and so on, enhance collaboration and cooperation, provide adequate funding for endemic countries, technical support, and more importantly perhaps, report updates on progress. Now, in the context of drugs, the role of pharma over the last 15 years or so has been absolutely critical. And it began really with the visionary donation of Mectizan, or ivermectin, by Merck in 1988. And that was a decision of a single individual who actually didn't consult the board of Merck at the time, Roy Vagelos. He recognized that poor people afflicted by river blindness couldn't afford ivermectin, even though it was probably only $10 per treatment. Since then, a whole range of companies have come on board, including Novartis, who provided multi-drug therapy for leprosy soon after that, GSK then with albendazole for filariasis, and more recently soil-transmitted helminths, and even more recently the donation of praziquantel by Merck Serono. The drugs for sleeping sickness are provided by Sanofi Aventis, and a proportion of the needs for visceral leishmaniasis by Gilead. More recently, the Japanese firm SI has stepped up to the plate to provide DEC for lymphatic filariasis in Asia. This is an interesting donation because DEC is probably the cheapest drug on the planet. One tablet costs less than 0.1 cent. It's a very, very cheap, sorry, a cent. It's a very, very cheap drug. The point about that is that even the poorest countries can't afford that, seemingly. The other major donation, of course, is for trachoma, is azithromycin, which is a really major donation because azithromycin costs relatively more. However, when you look at this table, the numbers and value of these drugs is extraordinary. My calculations, and they can be questioned, the value of these products are something of the order of $2 to $3 billion a year. That's annually. So these companies are committed to this, and in the case of Merck and GSK, of course, they're committed for as long as is needed. This is a huge commitment in terms of corporate social responsibility, and it recognizes the long-term needs of these products for poor people. Now, the current policy environment, aside from the continuing drug donations, is that this year we've had the World Health Assembly endorsing the Executive Board resolution for the control or elimination of NTDs in May this year. We've had a regional resolution at the Regional Committee for Africa meeting in Brazzaville in September, and David Cameron's post-2015 report on the development and poverty includes reference to NTDs. So 2013 has been a major year. So what are the platforms for progress for the next years, the next decade? Well, it is based on the huge donations from pharma. We have to maintain the branding of NTDs and the use of the expression NTDs and make sure the messaging is consistent and relate it to not only the current Millennium Development Goals but to the poverty alleviation agenda, and maintain the support for WHO because of its important leadership. Now, Margaret Chan has indeed embraced NTDs, I think because she sees that here she has a success story and a potential legacy. But she's actually transformed a bit of the thinking, because she said we are moving towards universal health coverage for neglected tropical diseases. And she put it in the context of the ultimate expression of fairness. I think this is a paradigm shift away from the concept of elimination and eradication, because the points she makes are that these are essential drugs. Now, just to reinforce the point that I made, that from the David Cameron et al. Report to the UN Secretary General, instead of just HIV, TB and malaria, we have now neglected tropical diseases mentioned as one of the targets for the post-2015 agenda. I would submit to you this is a step change in the way the world views these diseases. Now, I think one has to say, what is the rationale for this issue and why have we got to this stage? Well, it's quite clear that the bottom billion, as we've called them, of the poorest people who live on less than $2 a day are most at risk from these infections. And the drugs that we're able to give actually have an impact on several of the Millennium Development Goals, not just on the other diseases. Anemia is addressed through the value of albendazole and praziquantel in reducing anemia. The drugs also have an impact on the educational performance of children. And of course, anemia, if it's alleviated, has an important impact on maternal mortality. Women often die because they're extraordinarily anemic, particularly in sub-Saharan Africa settings. The interventions, because they are delivered to everybody, are highly pro-poor, and they therefore address an issue of equity. And Paul Hunt, the UN Special Representative for Human Rights, who's a professor of law at Essex, has identified the issue of access to these drugs in the human rights context. And that applies particularly, in his view, to leprosy and to filariasis. And we know that there is an educational impact of anthelmintics. So preventative chemotherapy is cheap, it's safe, and it's cost effective. We know we have successes, and the results are actually measurable. In many interventions, measuring impact is extremely difficult, but we're very confident we can measure the impact of these interventions. The latest figures, and it depends on how you stratify the information coming to WHO, is that some 700 million people plus are treated every year in 70 plus countries with drugs for preventive chemotherapy. And the other important issue is these activities are driven by public-private partnerships, which benefit not only from bilateral support but for NGO support. And in a meeting in Brighton in September this year, the NGOs brought together for the several diseases which they're interested in some 350 people. That's an extraordinary number of people attending one meeting when perhaps 10 years ago you had maybe had 20 or 30 people. The partnerships involved are compelling and they're diverse, and they reflect the evolution of the interventions over the last 15 years or so. Now, the point I want to make about the drugs which pharma give is they're all on the WHO essential medicines list. If you pick up the blue book of WHO, every single one of those donated medicines is in that list. So we have a situation here where pharma are giving $2 billion worth of drug, essential medicines, which if they were delivered, and the costs are limited as I'll show you later, those drugs would contribute to universal health coverage. Now, the other point about this is the strong involvement of communities, as we've seen from the onchocerciasis control program, which was pioneering the issue of community-directed drug distribution. In that program, and this is where we come to access, is the communities who collect and deliver the drugs. But 50% of the 80 or 90 million treatments given every year in that program are given to communities that live more than 20 kilometers from any health center. So it's about access of poor people to probably the one health intervention they can access, which is driven by communities. Now, we have to be consistent for advocacy purposes in our messaging. And many people, particularly the bilateral donors, are very keen on what the costs are and what the economic rates of return are. Now, it's been known for some time that many of the programs deliver economic rates of return on investment of between 15 and 30%. Indeed, when the World Bank did the analysis of the river blindness programs, they said that was the best investment the bank had made. This was 10 or 15 years ago. Now we know, and this is remarkable because Alan Fenwick and I and Vinan Antulya published a letter in Lancet in, I think, 2005 or 6, estimating on the back of the envelope what the costs of delivery were. And it really does appear to be pretty well on the mark. The latest figure, which comes from a published study recently commissioned by the Lancet from the World Bank, shows that the annual per capita costs in Africa for preventive chemotherapy is 0.26. It varies considerably from 0.6 cents to about 30 or 40 cents. It depends on the setting, depends on the drug. But we're not talking about a large sum of money. And I'll explain a little bit about that later. We also have the issue of multiple impacts. These drugs impact on other conditions. Helminths, scabies, malaria, HIV, and I'll allude to that in a minute. They're sustainable interventions. We've seen the river blindness program sustaining delivery at about 70% coverage over periods of 15 years by communities. People want to do that. And of the donated drugs, 70% of them reach the target population in any 1 year. So Margaret Chan's statement, we are moving towards universal health access for NTDs as being an expression of fairness, reflects what I call the 6 E's. So if you're writing this down and want to use it as a sort of a set of bullets, it addresses equity, the drugs are essential medicines, they're efficacious and effective. There is an ethical dimension to this because people actually are treated by drugs which are known to be safe. There's the issue of equality because the interventions are pro-poor, and in many cases we're targeting elimination. So the current policy environment is around these messages and platforms. The key question is whether countries will prioritize themselves and commit at least part of their health budget to these interventions, given that they're essential medicines. So in my view, there is an obligation. Now, 2 reports have come out. One published, this one published last week, I think, in the Lancet, which was the 20th anniversary recognition of the World Bank report on health, and a report by a consultancy company employed by the Gates Foundation, Dahlberg Consultants, who have both come up with the same figure. The shortfall in Africa for NTDs is between 150 and 200 million a year. And globally, it's around 400 million. The total annual cost of delivering NTD interventions is about $1 billion. There are people who are providing substantial funds of money, the main donors being the US and the UK, and for that we have to record our grateful thanks to DFID and the support it gets from our parliamentarians. But we have to maintain the advocacy in the face of competition for health resources, not only from the infectious diseases such as HIV, TB and malaria, the money going through the Global Fund, but also the growing problem of non-communicable diseases, which have been highlighted in the recent Chris Murray Global Burden of Disease report. Now, this was the paper which was commissioned by the Lancet, by Anthony Sedo and colleagues, including Don Bundy at the bank, which identified, particularly relating to Africa, what the costs of the interventions are. But their overall message is that the unit cost of delivery is 26 cents a year, US, which is not a great deal, to deliver essential medicines. Now that 26 cents includes issues of transport, social mobilization, evaluation and monitoring, and so on. So we have a very cheap intervention here. Now, how does that fit in terms of what countries spend on their own healthcare? I've taken two countries here, Liberia and Malawi, largely because our group in Liverpool are actually working in those countries. And the government of Liberia provides per capita $12 per person per year per healthcare. And coincidentally, that figure is also the same as Malawi. The total healthcare expenditure is a combination of personal contribution and the contribution from the government. That's about $20-odd. Actually, 0.26 cents, 26 cents, is a relatively small proportion of even the poorest country's expenditure on health. If you take the total expenditure, 26, it's coming out around 1%. Maximally in the poorest countries, it's about 3%. So all we're asking, if we want country commitment, is for countries to provide 3% maximum of their total expenditure on healthcare on delivering essential medicines. Now that seems to me to be a powerful argument to get a greater degree of country commitment. Interestingly, you can expand this to other countries. Niger, where Alan Fenwick's team has been working, has shown that the integrated costs of NTD delivery are 19 cents. So the costs are now becoming clear from a range of countries and a range of settings, and it's consistent. Now, one of the bigger problems that we perhaps face over the coming year and years is the management of partnerships. Now, I've been involved with the filariasis Alliance for some time, and what one sees in this slide are the logos of those groups of organizations who are committed to this cause, the global elimination of lymphatic filariasis by 2020. Now, this is a hugely diverse mix of individual organizations coming from different directions with different agendas, different financing mechanisms, different histories, and so on. The trick, this is filariasis alone, is to manage these entities and bring them together with focus to achieve the overall goals. This seems to work pretty effectively because the Global Alliance is actually regarded as an effective model, although it's based on a very, very loose governance structure, far looser than the rather structured partnership around the Onchocerciasis Alliance and other alliances such as the Trachoma Initiative. So one of the challenges we face over the coming years is the management of partnerships given the diverse actors that are involved and interested now in these diseases. Now I want to come to an issue which has occupied me a little bit, and that's innovation. And this is a statement, I think, from Gro Brundtland when she was Director General of WHO. If we are serious about innovating to address infectious diseases of poverty, we need to be innovative with a focus beyond product development. Innovation is very frequently viewed as people in white coats finding new drugs, vaccines, or diagnostics. The NTD community over the last decade, I think, has been highly innovative, but not in that way. Initially, we had to find out what, for the purposes of ivermectin distribution, what was the most effective way of measuring endemicity for onchocerciasis. And that resulted in the development of the rapid epidemiological mapping based on defining the numbers of nodules adult males had in communities. And then we had the problem of serious adverse events of lower, and we had to define where lower risk of serious adverse events existed. That resulted in the development of what was called the RAP-Lower survey based on the identification of eyeworms by the population in communities. Both these approaches were non-invasive. You cannot go around doing skin snips and blood films now at scale in Africa or elsewhere. So innovative ways of monitoring and mapping have been developed. These are just two. When it comes to innovation, I think the dose pole is perhaps the best example of having to avoid carrying scales around villages and weighing people. The dose pole, the height for weight to measure the number of drugs you get, is a highly innovative way of assessing the drug needs of individuals. And Caroline Harper, when she speaks, always carries a dose pole with her. In the guinea worm setting, the drinking straw to prevent you getting copepods is pretty innovative. And in Burkina Faso, all school children had an exercise book given by the government Ministry of Education, which told them how to not to get guinea worm and to filter their water. Now, also throughout West African markets, health education materials sold gave the message about guinea worm and how to avoid it, and was available in all markets in French-speaking West Africa, demonstrating the need to filter water. These were innovative solutions. They did not require very much insight, very little money, and they could be used at scale, and they could be implemented quickly. Currently, there is a huge momentum to use cell phone technology, given the extent of networks in Africa. Initially, first picture I took of a gentleman using a cell phone was on a guinea worm mission to Mauritania. And this is a cell phone being used by Sightsavers, the London School and ITI, mapping trachoma. And this is a guinea worm volunteer in a village using a cell phone to report a guinea worm rumour in Burkina Faso. More recently, Tom Nutman, and this slide is courtesy of him who works at NIH, are using cell phone technologies allied to microscopes to monitor filariasis in populations in Mali. These are highly innovative approaches using existing technologies which can be deployed very quickly. And perhaps the most innovative intervention of all was the use of the communities to distribute ivermectin by the onchocerciasis control program. Developed in the early 1990s following the experiences that mobile teams for delivering ivermectin were costly, they didn't access the populations adequately, and the populations knew what they wanted and when they wanted to deliver the drugs. As I said earlier, 50% of onco treatments, that's over 80 million, that's 40 odd million treatments every year, are given to communities more than 20 kilometres from a health centre. Some of the places you can't simply get to. And these people are not remunerated formally by the health system. Now I want to come to guinea worm. The one NTD, which is targeted for eradication. There have been spectacular progress on the guinea worm front. Last year there were only 542 cases in 4 countries: Chad, Ethiopia, Mali and Sudan, South Sudan. This year, last week, the current number is 140. That's a remarkable reduction. But that reduction is mainly in South Sudan. Mali, Chad and Ethiopia have stayed around 10 cases per year. This is a really significant achievement, and yet we're now in what we call in eradication terms the last mile. And one expects surprises during the last mile. And those of you who are astute enough to read journals online, this paper was published last week by Mark Eberhard and colleagues, entitled The Peculiar Epidemiology of Dracunculiasis or guinea worm in Chad. Now, those of you who know how the criteria have been established for eradication, i.e. no more transmission on the planet, will know that one of the criteria is the absence of animal reservoirs. The epidemiology in Chad has always, since it was found that it hadn't eliminated transmission, surprised us, because there was no pattern to the cases of guinea worm. They were sporadic, they didn't seem to result in new cases, and from a source case. And so the CDC team and the Carter Center team went to Chad and did some in-depth investigations. And what did they find? This is not the foot of a human, it's the foot of a dog. Very significant numbers of dogs in Chad are infected with guinea worm. From a molecular biological perspective, these worms are not distinguishable from human worms. The question is, how is this happening? And studies are ongoing, but the view is from Mark Eberhard that what we're dealing with is fish feeding on copepod populations and acting as paratenic or non-obligatory hosts, and those fish being eaten by dogs when the fish are harvested. At a particular time of year when the levels of the Chari River, which flows into Lake Chad, are actually at a level when the villagers can harvest fish in large numbers. So whilst we are optimistic that we can solve the guinea worm problem, we really do have to think about perhaps new approaches in this setting. And it was Bruce Aylward from WHO, who runs the polio program, who simply said, at the end game, you get surprises. And this is just one of them. So whilst we may be able to eliminate, in some settings, eradicate, hopefully, the issue of the dogs in Chad is a concern. Now, one of the points I want to make about innovation is that, as Gro Brundtland also said, good science is the basis of good public health. None in this audience will dispute that. But the challenge we face is to translate that into public policy. Now, the first member of staff of my institution was Sir Ronald Ross, who was awarded the Nobel Prize in 1901. And one of his first publications in the school was the campaign against mosquitoes in Sierra Leone. And he recommended the use of bed nets. Similarly, in the case of tsetse control, this is a man called Morris working in northern Ghana. And if you can read this, and it'll be online, Professor Buxton, who was the professor of entomology who wrote the classic work on tsetse flies from the London School, 100 yards away from here, went to northern Ghana in 1944 with a consignment of DDT, which he put on Hessian and impregnated tsetse traps. This was the first record I can find of an insecticide-impregnated material being used for vector control, 1944. How long has it taken for us to implement bed nets and tsetse control technology? We haven't implemented tsetse control technology at scale, even though we've known since 1905 that tsetse traps can work. The Portuguese showed that on Principe. How long did it take to get permethrin effectively into bed nets after Buxton worked on it during the Second World War in northwest Ghana? More current examples are niflornithine and nifurtimox for sleeping sickness. South Sudan studies by Simon von Nieuwenhoven in 1979 recommended that that combination was used. And it was only in 2009 that they were approved following studies by DNDi as a combination therapy for sleeping sickness. Similarly, ambisome. My colleague Michael Chance and Roger New in Liverpool published a paper in Nature in 1978 showing that liposome encapsulated amphotericin actually was a very effective cure for visceral leishmaniasis. Gilead donated ambisome at the London Declaration in 2012. That is the rate at which many interventions come into play. So if we talk about innovation from the perspective of science, it's a very slow process. And if you look at the WHO roadmap, we don't actually have the time to do it. What is the challenge from the point of view of delivery? Well, this is a slide which the group I chair on capacity strengthening in WHO came up with. If we're to reach the WHO targets to have the numbers of people treated by the end of 2015, we have to upscale rapidly. 348 million people require treatment for at least one NTD. The bulk of those people are in 5 countries: Indonesia, Nigeria, DR Congo, Ethiopia, and Tanzania. Africa, part of that, is around 250 million, of which 100 million are in Nigeria. Now, there is significant support now, thanks to DFID and USAID going into Nigeria, and an increased commitment from the Nigeria government. But that's the scale of the intervention. We have 2014 and 2015. Now, if you do the calculations, it means that we have to initiate continuous treatments for at least 5 years for NTDs in these countries at the rate of 10 million new treatments per year, per month. That is a huge number for countries which, in many settings, DR Congo and Ethiopia, are resource stretched. Now, I want to come back to a really important point about these drugs as essential medicines and community distribution. This is from a report on the Mectizan donation program, and it shows the numbers of treatments here approved by the Mectizan donation program up to 2010. These are approved treatments by the MDP in Atlanta. This green line is the proportion of those treatments which were approved which actually reach people's mouths. And it's between 60 and 70%. It depends on the year, and it probably depends on the reporting schedule. But of the numbers of treatments approved, a very high proportion reach people's mouths. If you take a World Bank study, starting with 100 drugs going in or $100 worth of drugs, this is published by a World Bank study in about 1995 by Ed Elmendorf and the late Ransom Kuti. Only 12% are appropriately used or complied with. So there's a loss of 88% of any drug going into the system. Now, if you look at the studies undertaken in Ifakara in Tanzania of antimalarials, their attrition of drugs is about 65%. But the contrast with this program, the Mectizan donation program for Onco and LF, is that 60 to 70% of the drugs approved reach people. That's a huge difference from the 12% in other programs. The other issue is the quality of the donated drugs. This is a paper published very recently in Lancet Infectious Diseases, and it's entitled The Poor Quality of Antimalarial Drugs in Asia and Sub-Saharan Africa. Summarizing this study, and I would recommend those of you who are interested in malaria and international health read it, 30+% of the drugs analysed by this study in South Asia were either counterfeit or sub-quality, and the same applied in Sub-Saharan Africa. The volume of counterfeit antimalarials is huge and increasing, and a serious public health concern. We don't suffer that with the neglected disease donated drugs because essentially their quality assured, and we've not got any evidence of counterfeiting. This is a very serious problem. Of course, it's unethical. Interpol are involved because of the criminal activities. It's a difficult issue because, according to Joel Bremen, who's the second author on this paper, the value of counterfeiting is more than the narcotics trade. That's the volume and the scale of this counterfeiting industry. Now, I want to come to something for those of you who work and know Africa, and that's the scale of the problems and the difficulties we have in addressing them. This is a map which Johnny Jarpong showed at a meeting in South Africa 2 weeks ago, and it's rather, I think, salutary, and that is that Africa is the size of the US, India, China, and Europe put together. That's a bit of a problem when it comes to drug distribution or even bed net distribution. And this is a slide I showed at my presidential address in 2007, but it's still pertinent because the problem I see in delivery of some of these programs in Africa is landlocking. 40% of sub-Saharan African populations live in landlocked countries. And I'm cheating because I consider that DRC and Sudan, South Sudan, are landlocked. They've got very limited access to the sea. I mean, you don't sail a boat up the rapids in the Congo very easily. And so this causes a significant problem. It causes a significant problem in terms of weight and volume. And a bed net weighs 450 grams. The NTD drugs can get into the size and weight of a bed net, and you can get, if you put praziquantel, albendazole and mectizan into the volume of the container in which a bed net comes, you can get well over 1,000 treatments. You can get those on the back of a motorbike, but you can't get 1,000 bed nets on the back of a motorbike. Nor can you get the volume of one treatment for sleeping sickness on the back of a motorbike. The infusions and oral salts required for sleeping sickness treatment for 2 cases of sleeping sickness are 1 cubic meter in size. Now this poses a problem when most of the communities live not only in landlocked communities in the Congo, but really have very limited access to any health facility. So in considering interventions, you really do have to consider the logistics and the weight problem. In Burkina Faso, I found 3 containers in a place called Mangadara, and I asked what they were doing there. And the containers had been left there. They were 1,000 kilometers from the seaport, Cotonou. And the point was, it was not worthwhile of the transport company to take the containers back to the port. The cost of the fuel would not be beneficial. They delivered each container 20,000 bed nets. Now, one of the issues which we've been addressing is the issue of comorbidity and disease burden. Prominently amongst these issues are HIV and urogenital schistosomiasis. We have problems of disability weights and NTDs, and some of the issues relate to mental health, neurological conditions and cancers, which are not attributed to NTDs, but are a huge burden. In terms of HIV and urogenital schistosomiasis, twice as many women to 3 times as many women, adolescent women, are infected with HIV because they have schisto caused by hematobium. Why the HIV community is not interested in doing something about it and giving praziquantel to adolescent females in places like Tanzania, Malawi and Zimbabwe, I do not know. We need to ask them, why are they not intervening and giving a free drug to young women to stop them getting urogenital lesions, which will, because of contact bleeding during sex, actually expose them to HIV. It's probably the most cost-effective anti-HIV intervention there is, but nobody's doing anything about it. And the Global Fund do not want to know. I think that's an international disgrace. The Global Report on Infectious Diseases of Poverty by TDR provided several options for action. One of them was to develop an index of infectious diseases as poverty to act as a marker for socio-economic development. So this could become a key advocacy tool. One thing we haven't addressed adequately is the issue of zoonotic diseases. 600 million people who are dependent on livestock are exposed to diseases of livestock which are zoonotic. We need to build much better local research capacity, and we have to be innovative, not just in terms of new products. We also have to be smarter about the use of IT. There are many issues which have been addressed by the research agenda. WHO has had think tanks on all these diseases, and Gates grant have been, the Gates grant for these diseases in terms of the chemotherapy and the needs of preventive chemotherapy and operational research are ongoing, including the issue of priorities for social science research. If you look at neglect, just pointing out the discrepancy here, 120 million people are infected with lymphatic filariasis. And in 1 year, this is a Thomson's Reuters report, 1,800 papers were published. If you compare that with intestinal worms, 1 billion afflicted, 10,000 papers. Compared with HIV, 34 million infected, 154,000 research papers. Diabetes, slightly more papers, but 346 million papers per million infected. The key thing here is that there's this discrepancy between the numbers of people and the amount of research and the impact of those diseases on poverty. Now, conflict is a major issue if we look into the future. Child soldiers, and recently in Nigeria, where I was working on the Guinea Worm Commission, Boko Haram made it very difficult to operate and for enable us to certify the absence of transmission. The weekend, a team from my group was there. Boko Haram shot some 40 school children in a school at the weekend. So these problems in terms of NTDs are going to affect how we progress. I mentioned Guinea worm. We had the problem certifying Nigeria. One of the teams in Niger had somebody who was accompanying them killed by friendly fire. We know about the problems in Afghanistan and Syria, but nobody's talking about the huge problem of cutaneous leishmaniasis in Syria and Afghanistan in urban centres. Conflict affects the provision and willingness of NGOs to work in those areas. And in terms of communities out of reach, we've just found Yanomami communities in Amazonas who are infected with onchocerciasis we didn't know existed. I'm going to move on, but essentially issues around mental health is something we've been working on. This is an executive summary from a WHO report on mental health and development. The key factors that they identify as a problem of mental health are exactly the same as those which affect NTDs. And I believe that the burden of mental health in many NTDs is extraordinary and needs to be investigated in depth. All these NTDs, Buruli ulcer, cutaneous leishmaniasis, onco, and so on, have a profound impact on people's mental health. And as a burden, certainly our initial calculations are that the mental health problems associated with people like filariasis are at least twice as high as the disability adjusted life years attributed to filariasis by the recent Global Burden of Disease study. So I'm coming to the end. The post-2015 challenges really about political stability and greater country commitment. We must recognize that these countries have limited human capacity, and that extends from both the communities to central government. We're going to face issues of environmental degradation and natural disasters and climate change, which are going to impinge on the epidemiology, which are also going to affect migration and so on. We're going to have problems over water-related issues and rainfall uncertainties. As always, there is a need to communicate between sectors: water and sanitation, health, education, and agriculture. And it may be that the NTD agenda is disrupted by pandemic threats, which the world always seems to respond to quickly. As far as research challenges, dengue, can we get a vaccine? Vaccinologists always say there's going to be a vaccine in 10 years. The malariologists have been saying that since 1975. Can we be effective in any vector control for dengue? We have some new drugs for trypanosomes and leishmania, but we're still a long way off from what we really need. Will the efficacy of our current anthelmintics be maintained? We need to monitor efficacy at scale, and we need pediatric praziquantel formulations. We need to engage the water and sanitation community. Monitoring evaluation of these programs are going to incur costs, as is post-elimination surveillance. I've mentioned these issues before. I look upon NTDs rather like the tubes you travelled in. We have many different issues. We have the global health policy line, we have the country lines, we have the research lines, we have the advocacy lines, and everybody plays a part. And these, like all networks, have to be coordinated. Sometimes you'll get blocks in the road, difficulties which you have to circumvent. But I was given this slide last week in Geneva by a former chief of aerial operations of the onchocerciasis control program, a man called David Baldry. David Baldry was the first person to fly the helicopters which started the onchocerciasis control program in 1974. And this is a slide of him talking to the villagers of a village called Waijin, just outside Ouagadougou. Every one of the people in that picture were blind. That will never happen again, thanks to the commitment of donors to the Onco program initially, and then to the Mectizan donation program. That will never happen again. There is nobody in West Africa, or indeed Africa, who will lose their sight from river blindness. I believe that the NTDs are markers, agents and drivers of poverty in over 1 billion of the poorest. NTD control, even elimination, can make a proportionately greater contribution, in my view, than any other investment in health. You get more health for less money. And it's our responsibility to articulate this policy message based on the strongest scientific evidence and existing programmatic success. And I come down to a statement I've made before. If we can't deliver free essential drugs to poor people, we're unable to really solve more complex issues of international health. NTDs are low-hanging fruit, and we have proven successes of control, elimination in geographic settings, and near elimination. And I think we have an obligation to maintain that momentum. Now, we've come so far in a relatively short period of time. Now, this journey has been one which I've been privileged to undertake over the last decade or so, and I'd like to thank the School of Tropical Medicine and Janet Hemingway in particular for her support, to DFID for their unstinting support over a period of years, GSK in partnership with DFID, the WHO NTD department under the leadership of Lorenzo Savioli, the Mectizan donation program, this society for the privilege of being able to be president and to receive the Manson medal, Nuffield Foundation and the European Foundation's Initiative for NTDs, which has played a major role, and many individuals, Peter Hotez, Alan Fennick here, Lorenzo Savioli and Jeremy Farrar, who can't make it, Moses Bokhari, Joan Fay, colleagues in Africa, Mweli Malachela and Johnny Jayapong in Ghana, many students, friends, family and colleagues. Thank you very much.